Hi there, this is Ron Myers from the consulting room, and it's my great pleasure to introduce Dr. Patrick Treacy today. I've known Patrick for close to 20 years now, having worked with him many times as a speaker at the FACE conference. Patrick's a dermatologist and runs the Aylesbury Clinic from several locations in Ireland. He's an author, researcher, and is dedicated to countless humanitarian efforts in many countries around the world. Patrick has also been awarded more accolades, I think, than I would ever have time to mention as well, including top aesthetic practitioner in the world in 2019. Patrick's a true pioneer and researcher in the field of aesthetic medicine, and I think with his wide variety of connections around the world, he's always the person to ask about anything related to aesthetics and dermatology. So Patrick, we were following a recent discussion. You mentioned that you've been interested for some time in the dermatological manifestations related to COVID. So I thought it'd be great, really, and really important at this stage as well, when clinics are going back to work, to outline, I think, what's been documented in the scientific journals to date to alert practitioners and estheticians to the types of dermatological symptoms that they might see. So, Patrick, just welcome anyway.
Oh, thank you for a beautiful introduction, Ron. You know, we always have this during every pandemic. We had it during HIV. We even had it during SARS for a little while, and that is whether the cutaneous manifestations of the illness are actually associated or not. We know that most viral illnesses give us a chickenpox type reaction. Almost any doctor, if they see some rash they haven't seen before, they almost know if it's viral or not. And that has happened certainly with this as well. With HIV originally, we had things like Kaposi sarcoma, and you know, it was actually our good friend Arnie Klein who picked that up first. But so when this started happening, because we had such big numbers of people with the disease and unfortunately associated comorbidities, we weren't sure what was part of the disease or not. So if I maybe could run through some slides I have here.
Okay.
And we could have a look at it. So you can see me there okay now, can you?
I can, thank you. Yeah, that's brilliant.
Okay, so originally, those three pictures that I showed you were the type of things that were coming in. And doctors in Britain originally turned around and said, maybe Spain should have a look at the dermatological manifestations. And I say this because this was the British Medical Journal had this one. So what they did was they took advantage of this, and they had 399 cases that was sort of referred in. Now, there were a loose association, unfortunately, because people were dying, and they had some people that had nasopharyngeal swabs, they had some people who didn't, and they had some people who had obvious COVID disease with the respiratory functions. They were in ICU, but they had only antibody tests. So there were a mixed bag of sort of patients that they had, but at least they were able to break it down into 5 categories. One was this exanthem that they sort of saying was like a, I suppose, all the world like a maculopapular rash that we tend to see in pityriasis rosea, actually. Then we had this cutaneous vasculitis, and I'll run into these in a moment. Urticaria was quite common, and this is the sort of things like people call nettle rash. Livido reticularis is obviously like an end-stage thing where tissue infarcts and it becomes almost necrotic. And now with these chicken pox blisters. COVID toes began to show up as well. A little later in the sort of pathology, people started noticing that there was almost like, I suppose, some of the children's diseases we have. When they get meningitis, you get infarcts, perineal-like reaction, and the ends of the digits in toes and feet. So we're into that. Now, I looked up this as of this morning, because that was the first results in from Spain about, I suppose it's about a month ago now. And as of this morning, just 46 different articles have been ran on over 1,000 patients. So even though the Spanish numbers were fairly small, they were actually quite good because it's about 400. So now it's up to different countries, and they present with, the biggest one now is chilblain-like illnesses, and this chilblain ones we see almost again like the infarction type thing. I'll go into that. The maculopapular lesions had dropped back. They were in first place. They're about a quarter now. Vesicular lesions are 10%. Urticaria lesions have gone up from 19 to 21, so it's almost the same. And libido necrotic lesions have dropped back to 2.3%. And then they have a new one that they brought in, nondescript rashes, and they're, I suppose, a mixed bag of different things. So we have this wide spectrum, I suppose, of cutaneous manifestations, and there is an increased awareness of what doctors should look for. And some of these ones come with symptomatic patients, some come with asymptomatic patients. Okay. So the general feeling is, if somebody presents with these type of diseases, cutaneous manifestations, skin rashes, and they haven't had any medicines within the last 2 weeks, they haven't had a history of a previous example of this urticaria or maculopapular, I suppose, skin rash, that they should be tested for COVID. So it's almost like the dermatological aspect of it has become in itself now, I suppose, symptomatic. So do you want me to run through just what the different ones look like, Ron?
That would be brilliant. Thank you, Patrick. Yes, please.
So we set first these vesicular eruptions. And these are small red blisters, a bit like cold sores, and I'll show you them in a moment. The sort of things we get in chickenpox or in herpes, and they're really inflamed blood vessels within the skin. Now, they're either purple or red, and they're usually found in the lower body, but they can appear in other places as well. And they last for 10 days, the same way as most viral illnesses last for 10 days. And believe it or not, even though they can come in the absence of symptoms, they're usually linked with severe disease. Patients in ICU show up the most common. And it's interesting, younger people tend to show cutaneous manifestations more than older people. So that's these type of ones here. So they're almost like, if you look at that, you say, oh my God, that patient has herpes, that patient has chickenpox. So viral illnesses tend to do this, and that's that exanthem we sort of get with it as well. I looked at an Italian study, and they also noticed that they were having these, and of them, they had the patients were clinically proven by nasopharyngeal swabs. They had no history of medications in the previous 15 days, so they began using this as a diagnostic criterion just for patients presenting with varicella type illnesses. So it's funny, if a patient like that came in to me, I'd probably be putting them on a little bit of steroids rather than sort of doing a COVID test. So apparently it's as basic as that. Yeah. You would know probably with that type of one there was something sort of happening. The second one was urticaria lesions, and these tend to show up because almost every one of them, 92%, have got a severe itch. And whereas only 50% are with the maculopapular, they spread across the body, then go into the hands, and they usually appear once the symptoms appear, and they're also associated with more severe, I suppose, illness to an extent. Yeah. And we shouldn't miss those. Urticaria is a fairly easily diagnostic criterion, and I presume that dermatography would be positive for these type of patients as well. All these pictures are actually COVID patients. Okay. Then maculopapular, up to, in the Spanish study I'm still running, nearly half of them have these. So these are these raised type bumps. And it has been described by many dermatologists as being similar to pityriasis rosacea. And most doctors in general practice or in dermatology would be familiar with that. That's a picture I took of pityriasis rosacea, so that we just know the sort of, I don't think that patient has COVID, but I sort of had put it in. Libido necrosis in aesthetic medicine, this is the thing we don't like to see, we know, because we also get this similar net-like pattern with vascular occlusions and dermal fillers. So that would tend to be a sort of a bad sign, because it's, I suppose, in the same, I suppose, reason as we get it in dermal fillers is secondary to occlusive vascular disease. And we know that there are clotting problems. A lot of people thought it was DIC, and that was misinformation going around social media. Certainly, anticoagulants have been used in later stages of the disease, and this technically is when the vessels get blocked up. We could reduce oxygen, particularly areas that are far away from the heart, like the legs and arms, and you get that type of picture. You wouldn't really mistake it. It's that net-like pattern.
Okay.
And as I say, that also appears with vascular occlusion in dermal fillers. And then these chilblain-like lesions, they've become very sort of much associated with the disease now to a large extent. And they're small, itchy swellings of the skin. Younger people tend to get them. They last for a period of about 13 days. And they were present, I suppose, originally picked up by the Spanish dermatologists, then the Italian. Later, the British ones. There was a study done about 200 patients in England that showed this as well. And that thing this morning almost put them fairly high on the list as well. So they can be painful or itchy. And this, I suppose, is the Spanish results per se that we get. I know the 6 there. The 5, I suppose, still would be maculopapular acral ischemia, is this COVID toes. We'll look at that in a moment. Libido, and this petechial type, I suppose, one as well. We got to realize, I suppose, a person is pretty sick when they get sick with COVID. And with this comes many things. We said this hypercoagulopathy earlier. The second thing, I suppose, this immune response. And the immune response, some of the, I suppose, skin manifestations show up when somebody is really ill. And when they mount a sort of an immune response, they themselves start attacking their own skin. So we've seen this many times in dermatology, where a lot of the immune response can actually present as a dermatological manifestation. And when patients go into this, we know this cytokine storm. This is the one that dexamethasone works really well for. That has a, I suppose, skin involvement on its own. And then obviously if there's lung tissue damage, neurological status, gastrointestinal tract, all of the pathologies that appear during the symptomatic, I suppose, aspect of the disease is related to one of these pathophysiologies. And some of them are associated with angiotensin converting to enzyme as well. This is an interesting one. We know that this is how the COVID gets into the cell. And there was, I suppose, a big scare originally with lisinopril or captopril or any of the angiotensin converting enzymes, that these patients may be more susceptible. But I thought at the same time, if they're using the same key and lock principle to get into the cell, so this is how the spike proteins actually enter into the cell through this backdoor entry through these receptors, I would have thought that they blocked it. And then the results started coming out the same way as I thought. Yes, they do block it, so don't be afraid, stay on these medicines. And now there's a new thing that angiotensin serum converting enzyme increases. So I suppose that people taking those tablets originally were told they were at increased risk. Then they're told that they were not at increased risk, that they were actually at less risk. And now it's sort of gone back out again. I suspect they would probably be at less risk. So these are these ACE inhibitors. That's the spike proteins, the purple bit. And that's how it gets into the cell. So obviously there's a simple way to block them. If we can block the receptors, then it can't enter the cell.
Okay.
And I suppose, again, reticular blue toe syndrome, which is COVID, libido, the pathophysiology. One of the things that we should look at as well is several new skin conditions have emerged as a result of prolonged contact with PPE. And this gives rise to pressure injuries, contact dermatitis, pressure urticaria, and also people who have excessive, I suppose, sanitation. They're getting side effects from the ethanol, particularly in the skin. So we know that these skin complications were originally shown around the world from doctors and nurses working in China. That is Korea. And then in Korea, they started wearing these protective things on the skin to prevent them, I suppose, having these type of pressure sores. This is in Italy, so it's across the board, and that's in Britain. That was in the front of one of the nursing magazines only a few weeks ago. And then we have skin problems related to excessive personal hygiene, and those nearly all involve breaking down of the epithelial, the epidermal barrier. We know that sort of you put alcohol on your skin for a long period of time, you're going to sort of get a contact reaction. And these were the type of things. This was somebody who disinfected her face 5 times a day and wearing a protective mask on top of it. So you can see, and you know, that isn't unusual. If you were to put alcohol on your face that often, then obviously it's going to cause problems. Now, one of the reasons that we suspect as well for a second wave is that people are sanitizing too much. Now, this is a bit like melanoma month, and I was supposed to do something this morning regarding sunscreen and, you know, whether people should be using sunscreen all the time or this blocking other things. And it's a bit like this as well, unfortunately, with maybe being too clean. Because we know that when we go out, when we touch dirt and all the rest, we're continually building up our immune system. Mm-hmm. We're 3.5 months inside, totally sanitized, everything clean. You know, the immune system's going to probably fall asleep. And as soon as the people go back out into the community, it hasn't had time to wake up to respond. So we think that that is contributory to a second wave. Again, this is somebody, excuse me, that had a contact dermatitis just from excessive hand washing. Comatose is an interesting one. And most of them seem to appear once we've got a successful viral response. And usually they tend to appear whenever the symptoms are subsiding. And because of this, we think that these microangiopathic changes are possibly due to an autoimmune reaction. But having said that, I've read somewhere that some people present with these. So there was some case in California that were asymptomatic, but most of the people who present with COVID toes would have mounted a full autoimmune response. And then I suppose this phenomenon we think is probably autoimmune related as well. Now, obviously coagulopathy comes into it as well, but with coagulopathy, you tend to get more infarction libido. Now, this is like almost like an inflammatory reaction. And these are patients with COVID toes. I think from what I remember, that patient didn't have too many symptoms. That was the Californian patient. Mm-hmm. And later in New York, then we started seeing this rash presenting in children. And the children started with a fever, and then they started getting these rash around their eyes and around their hands and feet. It's treatable if you get it early. They think it's a variant of Kawasaki disease. I know some of the British papers were putting it out that it was Kawasaki disease. I've seen that in the Express and I've seen that in the Mail. It doesn't tend to, it's similar to Kawasaki disease, okay, rather than as it has been reported that it was Kawasaki disease. And these patients obviously can get, they can die. Certainly, I think most of them die from cardiogenic shock. Unfortunately, you get inflammation of the heart as well. And this is the way that kids die. They can also get toxic shock, a bit like the strep. So a child presenting with that, particularly under the age of 5, probably a GP should be aware that this could be something a little similar to a viral illness that they would normally see with the fever and the little spots. But in this present, I suppose, situation, we should extend our parameters that bit more and say, this child could get toxic shock, or this child could get cardiogenic shock, and probably should be screened for COVID disease. So the big ones would be, again, urticaria, chilblains. This is somebody presenting even asymptomatic, maculopapular disease, libido, and then sort of acute infarction.
Excellent. So, Patrick, I mean, obviously, people involved, especially as you know, in the aesthetic community, don't necessarily have a broad dermatological background and training. So, what would you recommend if they come across any of these kind of skin lesions that they think could be COVID related or related even to people as well?
Okay, well, there's two things. Britain is slightly different than Ireland. I don't know whether they've changed it, because in Britain they were doing all the testing in hospitals, which left it wide open that the nursing homes weren't being properly tested. So that's the first thing. Then the second thing is, how are you testing them? So any doctor should be able to test for COVID. So obviously, if you do a nasopharyngeal swab, it takes 1 to 2 days to come back, and that's the most accurate. That's almost 100%. You're putting it in, you're looking for the virus. Antibody tests are a variant, and this is the reason originally when the Spanish started this study, the tests that were coming from China, I mean, and they were everywhere. You could get them for like €7 or €8. They were up to 30% false negatives, you know? So, I mean, that's really not good. So most of the sort of antibody tests you get now, they're probably about 12, 15 quid. They're about €18 in Ireland. They're about 94% positive. The problem is this: somebody presents to you, they really need a nasopharyngeal swab, and that probably is in a testing center.
Yeah.
If they're a friend and you just want to see, I mean, you can use the sort of COVID antibody test. And I've had to do one just yesterday on a patient that had AVR done 6 weeks ago. They put her in a nursing home, and there was 9 cases in the nursing home, including a doctor who was looking after the patient. So they brought her home, and then nobody wanted to go near her because they thought she had it. So we did one of those tests. They're okay. She came back negative, but one of the problems is the reagent. When I went to the pharmacy, he wanted this reagent back because even though he was giving me enough to do 1 test, it could do 5, and the reagent goes off after a few days. So I think if you're set up to do them, you'd probably need to be doing them all the time rather than sort of getting a friend to lend you some of the tests.
Yeah.
The antibody tests are very simple. I mean, you just prick your skin and it'll give a reading within 5 to 10 minutes, a bit like doing a pregnancy test. And the tests are getting better. There's originally, everything's coming up from China, and originally they weren't, I suppose, that accurate. I think if it's a child or if it's an older person, it's probably worth sending them to the hospital just to get a proper test. And I mean, they would have technically symptoms of COVID. Sorry, signs of COVID. In other words, almost like you need a temperature to have some fail-safe mechanism that everybody just isn't doing it for the sake of doing it. I think if we've got one of these illnesses in somebody, one of these rashes in somebody who hasn't been on medication recently, because some of the drug-induced ones look very similar, Ron, and hasn't had a history of it, that I think is enough to warrant a test.
Brilliant. Okay. That's wonderful, Patrick. I really appreciate that. It was really comprehensive, and I think it's going to be really useful for people just to really be aware of once they start seeing patients and clients again in their clinic. So one final question, Patrick. In your opinion, what impact do you think the pandemic will have on aesthetic clinics in Ireland over the next few months?
Well, I suppose I can talk for myself, per se. The interesting thing is this: we also do dermatology, skin cancers, complex lesions, complications, as well as the aesthetic aspect.
Yeah.
Now, one of the problems with doing a lot of surgery is the fact that in Ireland you get a lot of private medicine, and as a consequence you don't get paid for months.
Okay.
So you technically could be doing my backlog of basal and squamous cells, bringing back all my staff, and not get paid after a period that we've been missing for 3.5 months. So I'm just being honest about it. So mostly I'm focusing on the aesthetic aspect at the moment. And honestly, I've never had life so easy. You know, I can run it with 1 or 2 staff. I can, I suppose, do Botox and fillers with my eyes closed. And I realize, have I got the right business model? Am I putting myself through all this stress for nothing, you know? So I know that Britain hasn't opened yet per se. So I'll just run through what we normally have to do. So our waiting room is gone to a large extent, and all the things that are in the waiting room are gone also. All our products are gone, our magazines are gone, and patients are brought up one after another in their own time. Everybody's so happy to see you that there's no bad feeling around. Everybody's in a really good humor. They're almost like hugging each other. Now, you need a protective screen. So you can get 2 or 3 different types of those. Perspex is going to mark after a period of time. Polycarbonate is better, but then how long is this going to last? The screens you get used to very quickly. It'll not affect your business. You can hang them from the roof just over your desk. And most of our money is coming in now, certainly by credit cards rather than cash. And we expected that that sort of would happen. And the staff are wearing just masks per se, and then the doctors and nurses are wearing visors. Visors are very easy to wear. Honest to God, I think I might start using them myself for carbon dioxide resurfacing. They're far easier than sort of goggles. They look a bit scary, but they're not really, you know, I mean, they're very straightforward. I respect the older patients that are coming in. I had a patient in 87 the other day looking for Botox, and I advised her up for her. But most of the people who are treating, I know they could be asymptomatic in a younger age group, but most of them are between the ages of 35 and 50 probably, and probably aren't at an awful high-risk group. Now, we know that that's when you drop your, I suppose, your ability to sort of screen. What's the word I'm looking for?
Well, I suppose drop your
guard. Yes, drop your guard. And so they're the ones that could slip in the back door. So I suppose it's a two-way process. Can we infect the patient, or can they affect us? So for the older people, we tend to say, could we infect them? And sort of we treat them with over the age probably of 65, with a slightly different way than we do a 35-year-old.
Yeah.
And the patients are all given a COVID questionnaire before they start down to the clinic. They have to be in contact with people if they come back from different countries, a bit like GP practice is doing at the moment. And then they all get hand sanitizers outside. And we've got the whole, I suppose, signage up. Certain companies, I suppose, are making those, and we put those in the clinic before we opened up. And then everybody gets infrared thermometer. Those things are dead handy, you know. I mean, we got a better one, about 150 quid, and it goes from red to yellow to, green to yellow to red. And nobody has showed a temperature so far. I suppose we're open a few weeks now. And the patients accept it all very easily. Now, in the beginning, it's a bit strange, but you quickly get used to it. If you're doing Botox, you're doing the 16 injections to better frontalis periorbital, they can leave their mask on. For nasolabial, for dermal fillers, and for cannulation, we just drop down the mask, make sure that we wear our own. And I suppose you've got to be careful of masks, because let's be honest about it, most of the cheap masks are non-medical, and we just throw them in the bin, and you can get them so cheap now. I mean, you can get 50 for about 20 euros, you know. The medical ones are still going up in price. The N95s, you know, they're still making, I don't know what it's like in England, but in Ireland, those things are still making about 2.5 to 3 euros a pop. And we've got those UVC where people don't. You know, you could put in UVC fluorescent tubes and turn them on for a minute and you've sterilized everything, rather than a lot of these fogging machines that do the work or do the not. And one of our problems is going to be, as we open up now, also is the machines. First thing is that a lot of, I suppose, the radio frequency, the vaginal machines, the fat machines, you're not supposed to really be with a patient more than 20 minutes. So it sort of spoils that to a large extent. Then the machines have to be sterilized afterwards. So believe it or not, even though people are a little concerned about Botox or fillers, that's the easiest part of it, you know? It's, you know, if I get a patient in with a basal cell cancer, I'm going to be more than 15 minutes with them, you know, and everything has to be sterilized back down afterwards. So you'd almost need to be running 2 theaters, you know, to run on time. Because by the time the nurse has cleaned the theater again, there's a lot of downtime there, you know. I found as well, believe it or not, that Botox for migraine went through the roof with us, you know, and the full premise study of it. I seen
Bluetooth disconnected.
13 Botox for migraine in the first 3 days, and I felt so sorry for a lot of the patients. One of them had it for 100 days, isolated in a room. Couldn't walk. That really nice weather, that photophobia, that vomiting. And another patient who had flown in from brain surgery in India, who normally goes to London to get his Botox for migraine. And I don't know why they were all back to back coming to me. There must be some internet site they have or something like that there. And I felt sorry for him as well, because he had, you know, sort of 3 months of misery, you know?
Yeah.
So I presume the stress brings on the migraine as well. And they were all great, you know?
Brilliant. That's really, really interesting, Patrick. I mean, I think it's encouraging that, and I feel this as well from people that we've spoken to in Britain, that there's going to be a good bounce back, I think, for the aesthetic part of the market. And as you said, especially toxins and fillers, which you said are a lot easier to do and kind of stream patients through. I think you're right. I think the challenge really is more with the machine part or other parts of the aesthetic market that may take a lot more time or require more cleaning.
Absolutely. You know, it made me realize why a lot of these high street brands are just doing toxins and fillers.
Yeah.
It is so straightforward compared to my normal day's work, you know? Yeah.
I'm sure. Yeah. Brilliant. Well, look, thanks, Patrick. I really, really appreciate your time, because I know it's very scarce and you're very busy. So thank you very much again for taking time out to not only present, but also the time that you've taken to actually pull that presentation together. I think it's really valuable.
Especially now that I'm down in Hawaii.
Yeah, especially in Hawaii. Yeah, I know. Wonderful. Thank you, Patrick. Okay. Anyway, cheers. Bye.
Bye-bye.